And the problem with MS is the lag time from exposure to onset of the disease, at least clinical onset of the disease, is estimated to be about 7.5, 8 years on average.
Parts of Epstein-Barr virus, in particular the EBV-1 molecule from EBV, contains amino acid sequences that are common to central nervous system proteins.
The question then is, could you treat this disease by boosting the T-cell response to control the virus? And that's possibly how some of our most effective immunotherapies work. Hi, I'm Gavin Giovannoni. I'm a neurologist working in the field of multiple sclerosis, and I'm based at the Royal London Hospital in the East End of London.
I'm Tomas Olsson. I'm professor of neurology at the Karolinska Institute. I'm working since 40 years back with multiple sclerosis.
And I'm Brett Drummond. You're listening to the ECTRIMS Podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. Today we're diving into a subject that's become a hot topic in multiple sclerosis research, the role of infections. A few years ago, there was a huge surge in interest when new research strengthened the link between Epstein-Barr virus and MS. It sparked headlines around the world and reignited long-standing questions about whether infections might help trigger the disease. But this story is much broader than just an EBV trigger. Researchers are exploring not only how infections might contribute to the development of MS, but also whether they influence disease progression, and importantly, whether targeting these infectious pathways could open up entirely new treatment strategies. In this episode, I'm joined by two people, Gavin and Tomas, that have contributed significantly to the discussion on this topic. And together we'll unpack what we know, what we're still learning, and what this could mean for the future of MS care. Gavin, Tomas, thanks for joining me.
A pleasure.
So I think as a starting point, it makes sense to start with the initiation of the disease. So when it comes to a trigger for multiple sclerosis, what do we currently know about the role of infections, particularly, as I said in the introduction, viruses like EBV, and how strong do you both believe the evidence is that they may be a trigger for the disease?
So the epidemiology is quite convincing. It looks like you have to have been exposed to the virus to get MS. So it's a necessary component of the causation pathway. And the corollary of that is if you don't have the virus, you're protected from getting the disease. So that's why I personally think it's causal in the sense that it's the one factor we can modify. But it's not the only factor because the majority of people who have Epstein-Barr virus infection don't get MS. So there's something else that has to act on top of EBV. And this is where Tomas has spent his life researching all the other factors that contribute to the risk, not just Epstein-Barr virus.
Yeah, I would agree. I mean, the studies suggest that you have to have had Epstein-Barr virus infection before you can develop MS. So it seems to be a necessary factor. But on top of that, there are numerous other things that play a role. Things like smoking, obesity, sun exposure, etc., that somehow adds on to the role of Epstein-Barr virus.
And so I guess if we start to go into that in a little bit more depth, Tomas, I know you've had some recent work that started to look at it. Other groups have also started to unpack how EBV may actually be leading to the development of disease, and molecular mimicry is obviously a key component of that discussion. Can we talk about some of the mechanisms that are being investigated for how EBV infection may actually lead to triggering the disease?
Yeah, there are different options. One of them that we have worked on and recently published in Cell is molecular mimicry, meaning that parts of the Epstein-Barr virus, in particular the EBV-1 molecule from EBV, contains amino acid sequences that are common to central nervous system proteins. So a misguided immune response against these parts of the EBV-1 can be directed then against central nervous system components. And there are a few examples of this. The one we have been, or two of them we have been involved in, is a molecule called anoctamin 2, which initially was detected in an unbiased way and published, I think, 2015 or so. and where we in upcoming paper could show that antibodies, if you have antibodies against this particular molecule, you have an increased risk of having MS. And if you combine that with certain HLA types, you can get up to a 24-fold increased risk. Also, pre-MS materials have shown that you don't get these antibodies until you have had the infection, and that is followed by increases in nerve damage markers, neurofilaments. And then, apart from the antibody side, we published recently in Cell that while the antibodies occurred in like 16% of persons with MS, the T-cell response against this molecule is around 50%. And we could also show that experimentally you can get a pathogenic response from these Noctamin 2 specific T-cells. So that is a potential target. But then there are other molecular mimics. In our case, we published on alpha-B crystalline. A small part of that also plays a role in increasing the risk of having MS. And then the Stanford group has published another molecule called glial-cam that seems to act in the same way. So it seems like in a small stretch of this molecule from EBV, EBNA1, there are at least 3 molecular mimics that could play a role. But on top of that, there are other ways by which EBV could play a role. There are theories that the damage you get in brain, in fact, is an immune attack against the virus itself in the brain. It's mainly Francesca Aloisi in Rome that has been driving that hypothesis, and you get a kind of bystander destruction of CNS. And there are further theories that EBV somehow enhances accumulation of B cells into the CNS. There was a paper from the Tobias Derfus group in the same issue of Cell where we published. So having the kind of data suggesting that EBVs is necessary factors, I think now it's important to find out the mechanism, how this happens, which in turn could promote therapeutic avenues.
And we'll definitely get into the therapeutic side of things as we move on. Gavin, I want to let you expand on that if you want. And part of what I think I'd be interested in hearing your thoughts on, you already mentioned that there must be other things going on. We know that a huge part of the population is infected with EBV but doesn't develop MS. Taking this molecular mimicry theory, how much do you think it could be antigen presentation by the DRB11501, which we know is a large genetic susceptibility factor in MS, that is playing a role here in the presentations of either these EBV peptides or these molecular mimics from Noctamin 2 or glial-cam that could be explaining part of that story?
Yeah, I mean, the only way you can really bring in the HLA is that if it actually is a pathogenic T-cell response. And Thomas and I are probably on the same side of this camp, that we think it represents a T-cell mediated autoreactive response. Now, whether those T-cell responses are EBV specific or via mimicry is a moot point, and I suppose that would have to come up with therapeutic strategies. And there are groups trying to develop tolerance mechanisms, using these specific HLA mimics to try and switch off that T-cell response. One of the problems we have in the field is where we have other diseases that are triggered by mimicry, there tends to be a very short lag between exposure to the infection and the onset of the disease. Be it vaccine and Guillain-Barré syndrome, or enteric infections and Guillain-Barré syndrome, or streptococcal infection and rheumatic fever. Those lag phases from exposure to the infectious agent and the onset of the disease is usually weeks to months. And the problem with MS is the lag time from exposure to onset of the disease, at least clinical onset of the disease, is estimated to be about 7.5, 8 years on average. And so you've got to ask the question is, what's happening in that 7.5, 8 years? Now, I reckon we could probably bring the onset of the disease much sooner, because there's this big preclinical phase to the disease. And I don't really know when the disease actually begins. It may begin quite soon after EBV exposure. But then again, the other autoimmune diseases where we've got good serology evidence, say type 1 diabetes, the antibodies, emerge, the autoantibodies in inverted commas emerge a decade before the onset of disease. So I think it's very difficult to say MS is purely mimicry based on exposure to the virus and then onset of the disease versus the type 1 diabetes where it takes time for the autoimmunity to evolve. But what we do know with type 1 diabetes, by the time they present, the end organ is over and they've destroyed the beta cells. And so, I suppose you could argue that multiple sclerosis is different because, say, inflammatory lesion in an adequate pathway brings it to the attention of the clinician or the medical profession early. And so we've seen the disease long before there's much end organ damage. So I've tried to argue by analogy using these other diseases where we have better pathogenic pathways defined. And I'm not 100%, I can't be confident which one best fits MS. But what I do know is we have enough circumstantial and epidemiological evidence to start clinical trials. And you don't have to know the pathogenesis or have it pinned down without at least testing the hypothesis using prevention and treatment strategies.
Yeah, I think that's a really good point. One of the things that we do know about this is it's chronic infection. EBV tends to reside in things like B cells. So beyond the initiation, there's also a lot of focus on could this be driving disease progression? I'd be interested in hearing both of your thoughts on that aspect of it.
I think it's unsettled whether the Epstein-Barr virus infection is a kind of hit-and-run thing or whether it really takes part in the chronicity of the disease. I don't know really how one would be able to study that. The ideal way would be to have therapy, perhaps an antiviral that is highly specific for EBV, or even perhaps very efficient vaccination that somehow depletes Epstein-Barr virus from the body. I don't know, in the chronic phase we can also find autoimmune responses against these mimicry targets, also in established MS that has been going on for some time. So the immune response is there, but to be completely sure whether it has a part in driving the chronicity, I think is a very difficult thing to be very certain about.
Brett, what we do know is now that we've got better assays, we are beginning to find out that people with multiple sclerosis appear to have higher viral loads. They appear to have molecular evidence of latent lytic cycling. They shed more EBV in their saliva, for example. Their T cell and B cell response to the virus is much broader and deeper in terms of the repertoire. And they also have an abnormal T cell response to the virus. It looks like it's an exhausted, senescent T cell response, which is not unique to EBV. I think this is a feature of most chronic viral infections. It's a immunological evolutionary race between the virus and the immune system. And so what happens with chronic viral infections, you tend to see an exhausted T cell response. It happens with hepatitis, HIV. It even happens with SARS-CoV-2. And we see that in MS. So the question then is, could you treat this disease by boosting the T cell response to control the virus? And that's possibly how some of our most effective immunotherapies work, like alemtuzumab and HSCT, for example. And there is data showing that when you reconstitute the immune system in the presence of the virus, you rejuvenate the T cell response and it may control the virus. So I think there's a little bit of circumstantial evidence suggesting that the virus is driving at least some of the immunological findings. And if we can suppress the virus or at least control the virus with immunotherapy, we could potentially alter that phase of the disease. Now, how that's going to play out in terms of MS progression is another story, because it looks like you may have to target the therapies to the central nervous system for that. If the virus is driving it from within the CNS, then targeting the periphery may not be sufficient, which is what our B-cell therapies are doing at the moment, as you said in the introduction. The virus resides in its latent phase in the B-cell compartment mainly. And, if we target the B-cell compartment in the periphery, we're pretty effective at suppressing focal inflammatory activity, not necessarily the more smoldering CNS compartment. So maybe if we have a therapy that does get into the central nervous system, we will be able to modify that phase or that component of the disease. That's the hypothesis that needs to be tested.
I think I can add to that. I agree with Gavin. We know that anti-CD20, keeps people away from relapses for year after year after year, but still in the bitter end, people progress despite this, and that would argue for a kind of compartmentalized immunity in the CNS where these antibodies do not reach these EBV-infected T cells, for example. And then one could consider ways to get therapeutics into the brain. And that would either be small molecules like the BTK inhibitors, even cladribine, but also these modern techniques of TCAR processes, BCMA-coupled antibodies and so on, that could penetrate the CNS and kind of affect the intrathecal or intra-CNS inflammation somehow.
So I think we've sort of covered some of the existing therapies that may be having some benefits through indirectly targeting EBV. Maybe it wasn't their intention to start with, but if we shift our focus to, if we make this the target as a therapeutic approach, what is our likelihood of being able to have some sort of disease-modifying effect? And I want to talk about that first, and then I think we should also talk about prevention, because this is probably one of the first times in history where we're at a point where people are talking about, can we prevent MS in the long run? But let's start with targeting it. There's been a few approaches, immunotherapy approaches being looked at. Antiviral treatments is something that's being talked about a lot. And Gavin, I know that that's something that you have talked about a lot. So maybe let's start with you. What is your thoughts on what we should be doing in this space and whether you think it could have success?
Yeah, so we need a good EBV antiviral. To be honest with you, the current antivirals are only moderately effective. And so, there are certain pharmaceutical companies that I can't mention that have got programs to develop antiviral agents that target EBV more specifically. You're probably aware that there has been this epidemiological observation that people who have both MS and HIV, comorbid disease, who go on to highly active antiretroviral therapies appear to do very well from an MS perspective. And then on the other side of the coin, people who are HIV positive on these antiretrovirals are protected, substantially protected from getting MS. So we think it's the antivirals, not the HIV. And there's been some work done showing that tenofovir, TAF, is the component of the antiretrovirals that has the best activity against EBV, and there are some exploratory trials going on now to look whether or not they can be used as a treatment in MS. There's one, a European-funded one. It's run out of Bergen in Norway, and there's one out of Harvard in the US looking at that. But I can be honest with you, I've investigated the pharmacology of tenofovir, and it doesn't really have very good CNS penetrations, or the levels are not going to be high enough, I think, to suppress CNS EBV. So if it does work, it'll be working like an anti-CD20 on the peripheral EBV component. So this is why we need new agents. The anti-CD19 targeted CAR T cells, which Tomas has already alluded to. The good thing about T cells is there is no barrier. They go across into the CNS. We know that from oncology data. They are very effective at treating EBV-associated CNS lymphomas. And when you look at the viral loads in the spinal fluid, the EBV viral loads plummet. And we're now in phase 1 safety studies with a bit of efficacy going to come out looking at the CD19 targeted CAR T cells. I would not be surprised if they're incredibly effective. Based on what we've seen in lupus, we hopefully will see similar results in the MS population as we've seen in lupus. I've already mentioned to you, I think alemtuzumab and HSCT are working as immunotherapies. So there is a vaccine company, I'll be frank, Moderna, who's now developing a therapeutic immunotherapy vaccine to try and boost T-cell responses. My worry with that hypothesis is because the MS population has seen the T-cell compartment has seen the virus all the time. The virus is there. Will the vaccine be sufficient to break the T-cell exhaustion? Just giving a vaccine, will that be sufficient to boost those T-cell responses? My personal opinion, we should have probably done a little bit more work on that before going into a definitive trial. Maybe it needs to be combined with a checkpoint inhibitor to try and break that T-cell exhaustion, which happens in the oncology space. A lot of the oncology vaccine trials now are not the vaccine on its own. The vaccine is being combined with a checkpoint inhibitor. Yes, so there's lots of activity happening. The problem is, and I think, is that our current therapies are pretty effective at switching off focal inflammatory activity. And then we look at our patients and think we're on top of things, and then we're not on top of things. And how do you design trials that can be done quickly enough, empower them sufficiently to give an answer, when you've already got such effective therapies that suppress focal inflammatory activity. So trial design is a big hurdle to getting these new therapies into market.
Thomas, anything you want to add into that space?
Not really. I think Gavin gave a kind of complete scenario on what could be done and what is done. I mean, he mentioned also this tenofovir trial. We are part of the EU consortium from Bergen, where we do the immunological analysis of the effects of that treatment. But apparently it doesn't penetrate the CNS so well, but possibly get some hints from that trial. One would like, of course, a much more specific EBV antiviral than tenofovir or acyclovir, or in fact, 20 years ago, there was a trial with acyclovir in MS, or 30 years ago, which had a borderline significance. In fact, it targets herpes simplex type 1 and 2, but has possibly some effect also against EBV. In the, you have the whole series of herpes virus cousins where EBV is included. So I think there are some hints. And as Gavin mentioned, the effect in HIV-infected, but you could argue could it be the immune suppression due to HIV or the tenofovir component in the treatment? But there are hints. So if a drug company comes up with a more EBV-specific antiviral, that would be very interesting to test. And in fact, I would prefer that route of trials in favor of vaccinations, but we can discuss that later.
Yes, I think Thomas is talking about therapeutic vaccines, but I suppose, Thomas, we've discussed this before in terms of, and Brett, we might as well get on to MS prevention. In terms of population MS prevention, having a prophylactic vaccine that's given before people are exposed to the virus. And I suppose that's not going to get licensed for preventing MS because that study is just not possible to do. It would have to get licensed to reduce or prevent infectious mononucleosis. I personally think there's a rationale at a population level to prevent IM because infectious mono is not a benign self-limiting illness that people think it is. It's a pretty unpleasant illness. So if we can offer young teenagers or military recruits or university students the option of not getting IM, I think they would take that. And that we think that if we can reduce the incidence of infectious mono, which is a bigger risk factor than just asymptomatic EBV seroconversion, we may be able to reduce the incidence of MS. And that's a separate study that's got nothing to do with MS, that's got to do with population health. But I think we need to do that study as soon as possible.
One can perhaps then refer to the effects of the HPV vaccination. The guy got the Nobel Prize for connecting HPV to cervical cancer. Oh, the name slipped out. He died a year ago.
Sirhausen.
Yeah. What we see now is the incidence of cervical cancer is indeed decreasing dramatically. But what we also see, my wife happens to be a nurse and having to take care of youngsters with genital warts. It was a big problem, and that has completely disappeared upon the HPV vaccination. I think perhaps the route Gavin is suggesting to have a vaccination at a certain age could be something. But there are always people arguing that we have co-developed with HPV through a million years or something. Could we create something terrible with, affecting this virus that we kind of are adapted to? But this is highly speculative, I would say. There are such arguments.
My personal opinion, though, my counter-argument is it's unlikely that an EBV vaccine is going to be sterilizing, in other words, prevent wild-type infection. The complexity of EBV makes it unlikely. So I suspect, even if we have an effective vaccine that prevents IM, but it's unlikely to prevent re-exposure and, wild-type infection with circulating virus. So that argument may be a moot argument in the sense that, until we actually have a vaccine, we won't be able to even address that question. I must say that there have been some small studies looking at older people that are EBV negative, that never got the virus, and they look like they're fine from a immunological, and there doesn't seem to be any consequences of not having the infection. So maybe this is just a theoretical concern. We'll have to answer that once we get a vaccine. That's my argument. It's not a reason not to do the study. That's why,
Well, I mean, it's an exciting time that we're in where we can actually think about a possibility of potentially reducing the incidence of MS.
We know that IM is a risk factor. So something happens during IM. So what we do know about people who have IM or asymptomatic is that the immune system control of the virus is defective. There's a dysregulated immune response during IM. So the other strategy is if somebody gets IM and you diagnose it, maybe just treating IM with an antiviral may reduce the incidence of post-IM complications. And the analogy there is streptococcal throat infections. When the antibiotics came out, sulfonamides and then penicillin in the 1950s, the incidence of rheumatic fever just plummeted. So something happens during the actual acute infectious phase of IM that may be modifiable with an antiviral. So you're not vaccinating people, you're treating the IM with an antiviral. So that's something I am very keen to try and promote, that hypothesis, and create the at least the unmet need for treating IM. It's actually an unpleasant illness. People who have IM don't like it. They often remember it decades later how unwell they were with it. So if you can actually treat IM, it would be a good thing, I think.
I should also mention here that both having had EBV asymptomatically and having infectious mononucleosis have kind of different risks. I mean, they add up to each other. So having infectious mononucleosis clinically adds to the risk of having MS on top of having had the infection even asymptomatically. We have epidemiological data suggesting that.
Gavin, Tomas, thank you both so much for your time today. I think really clearly explaining what we know so far, but also showing that there is still a lot of questions that remain unanswered in this field, but also for all of your hard work, really progressing this field to where it is today.
Thank you.
And thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MS Translate. The ECTRIMS Podcast is produced and hosted in collaboration with two key partners, MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community, and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2025-26 ECTRIMS Podcast series is supported by educational grants from Alexion AstraZeneca Rare Diseases, Bristol Myers Squibb, Roche, Sanofi, and UCB. Educational grant providers have no input in the podcast content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu, and do subscribe to the ECTRIMS Podcast on your favourite podcast channels, including Apple and Spotify, and follow ECTRIMS on X, LinkedIn, Facebook, and YouTube.